again, let's make a start of this final panel for this afternoon session. We have already our panelists with us. This second panel is going to be quite ambitious. You know, we've been spending the whole day trying to decipher not only which are the values we should align AI with, but also how we can help to AI to behave ethically. I'm talking about the AI as AI has an opinion on how to behave, right? But at the end of the day, this is what we are trying to. But don't forget that at the end of the day as well, AI systems are created, are implemented, are used by human beings. So we are those that should be deciding on the values to equip the systems with and to check that systems are morally acceptable. But these questions, as you know, are very big, are philosophical questions that need lots of reflection. So we are going to be starting this final panel with 5 brilliant panelists. Professor Payam Barnaghi, we already were listening to him before in his talk. For those that just arrived, that I know that there are people that have arrived now. He's a chair in machine intelligence applied to medicine at the Great Ormond Street Hospital, and he's also deputy head of division of neurology at the Department of Brain Science at Imperial College London. Then we also have with us Professor Susan Shelmerdine. She's a pediatric radiologist, honorary associate professor at UCL Great Ormond Street Institute of Child Health. We do have with us as well Dr. Nenad Tomasev, who's senior staff research scientist at Google DeepMind. And then we have also Dr. Ellie Asgari, consultant nephrologist, AI expert at Guy's and St. Thomas's NHS Foundation Trust at King's College London. And finally, we do have 2 patients representatives with us today, Jenny Wilson-Bradley and Emma Shellard. Thanks very much to all of you for joining in the panel. So, again, as we've done this morning, we would like to start by making a question to each of our panelists. This is going to be a question that has only one answer, yes or not. And then you should be able to give a short sentence if you want to justify your option, okay? Let's going to start by Payam. So the order is going to be the same order as you are sitting. Don't leave, don't go running. So Payam, you're the first one. As the group lead for translational machine intelligence in the Care Research and Technology Center at the UK Dementia Research Institute, which is very long, you have experience in developing AI to deal with dementia. We're talking about empowerment of patients. Can dementia patients be empowered to make informed decisions when an AI system is in place?
Yes, is the short answer. When we started this study, practically we build a big brother. We monitor people's sleep physiology, everything. I thought people would be very reluctant to do that. I expected a lot of people would drop out from our study. In reality, telling people transparently what you collect, what you do for it, and giving them access to their data empowers them. Like a lot of our patients will take their data to their GPs. Very different than saying, I didn't sleep well for the past week, than telling this is my sleep data and how you can look at it. Sorry, I gave a long answer for you, yes and no.
It was okay.
Okay, and for Susan, the same question, but applied to the field of childhood. Should children also be educated on AI so that they can make informed decisions too?
Yes, absolutely.
Yes, absolutely. Okay, wonderful. Next, no, I'm sorry. You want to spend a little bit more time.
You can give an justification.
Yes, of course.
As digital natives, a lot of them already have an understanding of AI, but they don't know how it's being used in their own healthcare. And I think a lot of them would like to know that and would actually be like to be part of the decision-making process. So I think educating them and also about the healthcare and how that can improve would be hugely empowering for them.
For me, that is extremely interesting because the people that we're doing like a cognitive bias, thinking that some groups of people would not be aware of understanding AI or making informed decisions, and that's not the case at all. So, Nenad, yes, thank you so much. Oh.
It's like Eurovision, we are changing.
So, Nenad, your turn. So you were in the programming team of AlphaZero. AlphaZero is an AI system developed by Google DeepMind that learn to play chess without human supervision. you think that in the near future, DeepMind will be delivering systems that can diagnose or can treat a disease without human supervision? And there's a second question for you. Would that be ethical?
I'd probably say no, based on the second question to an extent. Now, whether it is possible to kind of come up with systems that themselves learn how to make recommendations or make diagnoses, I think that may be a different question. But whether it would be ethical to use such systems without human supervision, I mean, it should be the use case that we have in mind that informs how the technology is built rather than the other way around. So just because something can be done doesn't mean that it should be done, right? So that is the deeper philosophical questions that the panel is going to try to answer, I guess.
So DeepMind is not going to be taking up the job at the moment.
Ellie, you are working on using AI to identify patients as risk of no attendance, medical adherence. Can AI reduce the rate of patients not attending their visit?
Yes.
Yes, it can. Yeah. I like this kind of answers. Yes.
Yeah, I think this is a big problem in the NHS. A lot of people do not attending, and there are companies working on this. I think there are two elements to it. The AI can't reduce the thing. The AI can understand and predict the risks of why people don't attend, and then help us find solutions for the problems that then the AI figures out. So that in that indirect way, it can help.
And then we have kind of same question for the two patient representatives, which is, as a patient representative, well, it's two questions. Do you think that you should be informed that an AI system is in place to make important decisions on your health? First of all, you should, because the GDPR Article 22 says that you should. But I want to know your opinion. If you think that you should be informed, or it's just fine, it's just one more tool, you don't really mind. And in case that the AI is in place, do you think that, would you feel that there will be a benefit of using it for you?
So I'll go first. Absolutely, yes, patients should be informed. I would be very concerned if they weren't informed. The concern I have with AI is who holds the control. And the control should always be primarily with the patient. And where the patient can't be in control for whatever reason, ill health, mental instability, whatever the problem, it should then be the clinician secondarily and not AI. So that aside, AI, yes, it can be useful and should be used because it holds a lot of information and a lot of opportunity, but it should never govern, it should never rule and dictate.
I think, yes, absolutely be informed. I think in mental health we are not informed of nearly everything. And I need to review all my psychiatric notes with horror, probably. And in terms of benefit, yes, but the way it's heading is, I'm positive about it, probably because I have ADHD, so it speeds up my existence. But for my fellow colleagues I interact with who are in public patient involvement, Satlan and Maudsley, I think they would be quite horrified. So, and there's a lot of not digital natives amongst us, so not myself, but but for dementia I can't really comment because it's not my area, but sometimes I think AI would be better than my family members, so yes.
That's interesting because it relates quite closely with my first question to all of you to start the panel. Talking about values alignment, the question is how we could identify the fair principles for alignment, principles that could receive reflective endorsement. Do you think that, for example, these values should relate with making us happy, making my family happy, making myself happy, or maybe related to universal law like fairness or justice? Or should these values be meeting human desires and volition that can be changeable over time? So what are the principles we should be following to decide what are the ethical values and to align AI with? Payam?
Easy to answer, but
Interesting point, because something can be done doesn't mean we should do it. And do you hear an echo? Or?
I didn't hear you before. I think that we can hear
Maybe
you better now.
okay.
Yeah.
Like when we started our dementia research, we worked with a product which was monitoring people's location. It was something you could wear and look like it was a GPS tracker, but they have made it on purpose very difficult to open it. And then we were feeding that across with other modalities we were collecting. And because it had been made not to be easily open and be like waterproof, look like literally like a prison tag. And the first day we took this product, I gave it to some of our colleagues in the lab and asked them to just walk to a local supermarket, see how it works. And they came back and they said, you know what, everybody was staring at us. What is this device we are wearing? Then it starts like with the values of, if you're developing, you have to put yourself in the shoes of people who are going to be the receiving end of it. Will you use that? Will you do that? And then if you start with that principle of sort of creating a product which has the value and also sort of complies to very certain principles of whatever the ethical boundary you're working or values are. And also in terms of the trust, I think Susie had a very good point. A lot of the systems, we always focus on the technical aspects of them. When we talk about AI, rightly, there was a question about explainability, and I think they should be explainable. But if I'm taking a blood test and my GP says you have, I don't know, your blood sugar is high, I don't say explain it, what that machine told me. In reality, that machine takes probably my blood sample, does some centrifuge, does some, actually there is a computer system behind it which counts, I don't know what glucose level. But I don't question that because there is a trust and that has been tested. I think it goes back to, yeah, you set some principal values and you ask to comply to that.
Yeah, I completely agree. I think at the heart of everything, we should be focusing on care and well-being rather than happiness, desires, because at the end of the day, we're all patients, and we all will be if we're not already, and we want good care, and we go to the hospital for health care, and so I think well-being and health care should be at the forefront of what we're focusing on.
Yeah, I think this is a very big topic. I mean, these answers obviously cover a lot of that space, but when it comes to value alignment, that particular term, when it's phrased that way, I think people mostly use that phrase when they want to refer to very powerful, more general AI systems looking forward into the future towards human-like, completely general systems. And this is why there is worry about value alignment, because there is a notion that those systems will internalize and hold certain values, and we want for those to be aligned. I think when it comes to AI as it stands today, and this is pretty much everything that's being deployed in healthcare across various types of use cases and work streams, these are more specialized systems, something for radiology, or as you say, interpreting blood tests. I don't think there is as much value alignment there. The kind of issues that come to the forefront are issues of fairness, issues of bias. Explainability was mentioned. I kind of agree that very strict validation is maybe more important than that, but in any case, those are the kinds of issues that come to the forefront. And then when it comes to the values and norms that influence how we design these more holistic, not just purely technological solutions, but solutions that involve pieces of technology, clinicians in the loop, patients that participate in their own care, and so on, then values come into the conversation again, because you said it's about well-being, and I fully agree. We've had a kind of an in-depth view into how to design well-being aligned, let's say, systems in one of our recent studies as well. I think in healthcare, when it comes to management of care, when you have a diagnosis, well-being really becomes a factor, because there may be multiple treatments you can give, or in different ways. They have different side effects, lifestyle consequences for patients. And obviously, they should have a say in how they make those trade-offs, because they are trade-offs, right? But then at the moment, at least, those are more human decisions made by clinicians rather than decisions made by the AI. So unless we're thinking like really forward into the future where those types of decisions will be made by an AI system, probably value alignment at least in a sense in which we normally use the word within the field, would not kind of correspond to what we're having to face right now, I think.
Ellie?
I think this is, I'm very factual-based person, so I think when it comes to words like fairness and happiness, I think that are very not easily standardized. I feel like it's very hard then to have value alignment on those. I think in somebody, and working in healthcare for me, I think it's what is important is defining, first of all, what we mean, and then decide how we are going to align. So I think there needs to be an alignment from what the government says, what the people want, what the healthcare professionals are working towards, and then after we clarify that, have a dialogue about it, and then make sure that we all have the same understanding of the words that we use, then we have like a plan. Because it's very different. So the government comes out with a 10-year plan that emphasizes on prevention, and then you go to the kind of GP practices and want to sell them a product that helps with prevention, and there's no money allocated for that prevention. In secondary care, I want to implement a kind of something that helps people not come to hospital, but the commissioning works that we get paid if people do come to hospital. So that's what alignment in my head is about. That for me, it's like having the best healthcare, preventing people from being ill, and getting the care they need as early as possible. That would be if I want to summarize it in one sentence, that's what I would say. But then how we put it all together, so then incentives, work towards developing products, all go into that, then that's the work that I feel that we should be doing with patients, with policymakers, with clinicians, and all together.
I was thinking about Susan, about your talk before. So you were presenting this white paper, presenting some standards, right, to be used on AI for radiology on children. So you had to make a decision here about what were the values that you were involving. And so you already did that. So there were a list of values in some way that you were choosing as the important ones.
This was an agreement among 7 societies, so there will be many values that were not agreed upon, that were not there, but there were some, the minimum standards that all of us could agree on were presented. Just to make that clear, this isn't like an exhaustive list. These were just the minimum that people could agree upon. But yes, I mean, those values were basically practical steps that each person could take in their society, in their hospital, in their institution, that could guide them on how to do things in our group well, that, what we define as well and safe. But it is hard to get to that collective agreement because, as you were saying, there are so many different parties involved and many different aspects and influence circles that you have to engage in order to come up with a collective group. So does it mean that we have a minimum set of values that we work towards, and then different subsets may have extra values that we then try to aspire to? I don't know, but it's hard to please everyone is the summary of that.
What is important for patients in terms of values? What would you highlight for you?
Given this some thought, and I thought, and I come at this from a mental health point of view, so bear with me with the psychology on this, but there's a thing called Maslow's hierarchy of needs, I think I've got the name right, which I'm not sure how many people are aware of, and there's various layers, and you have to go through the layers to feel effectively happy. At the base, you've got physiological: can you breathe? Are you sleeping? Are you able to eat? The next one above that is safety and security. And you have to ask the question, does the patient feel safe in this environment? Do they feel that they're looked after? Do they feel that they can let go and let whoever is in charge be in control? And I just wanted to pick up on the question you asked, or the mention you asked about blood tests. You don't question whether a blood test, if you've got a low blood sugar or a high blood sugar, you don't question it. I do. And I actually don't know anybody who does. I don't know anybody who hasn't been given a diagnosis of something, whatever it is, whether it's cancer and there is no answer, or something that's far more, they've broken it. How did I do that? Why is that there? How is that? If I got osteoporosis, does that just happen because I knocked it? I don't understand. You want to know the answers. And that's where I think you do question things. I don't know, maybe you're a lot more okay with not asking them because you're a clinician and you trust the information. But as a patient, I don't know my clinician from Adam, usually. I'd like to know them all. Generally, there's a reason I don't. But you have to understand the patient has their own sense of safety, and that's going to be different per patient. You go above that and you've got love and a sense of belonging and connection. Do you feel connected to your clinician? Probably not if they're AI. You've never met them. They don't know you. They're not a person. You've got self-esteem and need to be an individual. I don't think AI will be able to make me feel an individual. And then you get on to self-actualization and being able to feel happy. And you won't feel that until you've gone through the levels. That's the theory. In my experience, that hierarchy of needs does make a lot of sense.
I don't have much more to say, but in terms of, I was sitting in a risk analysis, and that's a difficult term in psychiatry and mental health, especially for patients, and something I think we're going to move away from. But risk and safety, I think it could be an interesting angle. I was part of the RADAR study, thank you, Kings, and many other places. I found that very interesting to be part of, and yeah, having the device on all the time, or just a, whatever it was, Fitbit. But then how it analysed my algorithms and haptics and all kinds of responses. But how can I really have, say, an alert from feeling anxious when it's just something very chronic for me, like I've lost my tights or something, or to having a major episode? That scale is gigantic. But I think I think it'd be great to have AI input now for our risk and safety project, is like 2 years worth. But I agree with absolutely all that. Very, very difficult. And on behalf of my fellow patient service users, utter terror, they would want me to say that.
It's very, very interesting. I was just thinking if it would be interesting as well to understand a little bit what is the role of each of us to make the AI ethical, for an ethical integration in healthcare. I was just thinking if we should differentiate about between the role of clinicians, patients, and developers. We have a representation here of each of you. And about the role of the clinicians for making this integration ethical. Do you think that clinicians should become automatically human in the loops so that help or work together with developers to identify, for example, risk of bias by assessing the responses or the decisions made by an AI system? So, and this is plausible, that can be happening. You think that clinicians will be open to become this human in the loop for the integration of AI?
Excellent point. A lot of time when the AI algorithms are designed, not always, but often when they're designed, this connection between the domain expert and data often is not like tightly there. But like you get a bunch of data, you have a target, and you design a model. And you evaluate it, and then you give it to a group of people to use it, and they give you feedback. The risk is here is let's say if I've designed an algorithm which screens for risk of cancer. I say my threshold of my algorithm, let's say for sensitivity is 90%. Looks good probably, and a regulatory will approve me. That 10 in 100 I miss, they will face consequences. And the risk is here, I sit in a lab and I write Python code and I design an algorithm. I don't see the human consequence of it. A doctor which treats those people, a patient which goes to a clinic will see that. And that, if we are not very careful as a society, changes the way like our warfare has changed. Now I can sit somewhere very remote, thousands of miles away, I can control a device which can be very destructive. Now, I'm not saying AI is going to do that, but if you're trained in medicine, you learned to see the consequences. You see the patient, you come to the patient, next day is not there, you know what has happened to that patient. But if I design an AI and my AI is 90% accurate, I don't see what happened to that 10 people, right? And I think that's where it comes like really you should integrate right from the start people who actually operate that AI, people who are going to be the end receiving point of that AI to understand the consequences. Just one last thing. I went a couple of years ago to a conference, very different topic, but there was a group, a very prominent group, they were designing surveillance videos. And somebody asked about like recognizing faces in crowd. And somebody asked this question saying, you design this algorithms, this could be used, and I come from Iran, like Iranian government uses that. To detect when people protest in the street. I didn't ask that question, but somebody asked, and I said, do you feel about the consequences of your design in this technology? And the answer struck me. This was a very, very prominent researcher, one of the leaders in the world, he said, that's not my job. That's somebody else's job to think about it. I designed the tech. And I think we have to be careful. Healthcare is not treated. I sit in a company or I sit in a research environment. My job is to design the algorithm. Is your job to look after ethics because there is in your title or something?
Yeah, there's so much in that to unpick. First of all, I agree 100% that in my specialty, radiology, I am a step removed from patients compared to other doctors. And one really interesting study in radiology was that if they put the picture of the patient's face with the scans and showed it to patients, doctors reporting the scans, they found in one study that radiologists were more likely to spend longer time looking at that scan and took a lot more time thinking about the consequences of their report than if they had no patient picture. So in our electronic health records, there's actually a picture of a patient on every electronic health record. So every time you open it, you see a picture of the person that is behind all of these notes, which is hugely impactful. But I agree with Payam that we should be more collaborative right from the start. I would advocate that, in medical school as a doctor, we start talking to engineers or data scientists and working together, trying to form a specific language that allows us to understand where they're coming from, where we're coming from, what the issues we have versus what are the issues in terms of creating an AI model that they have as well, so we can get the best product for care and well-being in the future. In terms of a clinician in the loop, I think I have a few different ideas on that, because I think when we think about the ethics of including a human in the loop, it's obviously the best possible solution, but we can't have enough humans to constantly be in the loop for everything, for a greater need for healthcare, for increasing scans, for fewer workforce. How do we still maintain that human touch within that? And we're not very good at recognizing the bad effects of not doing anything. We're very good at looking at the disasters if we do something, but if we do nothing, that's also bad. So one example in radiology is we have a huge backlog of unreported scans that are just waiting on a pile for someone to go through them, and no one's going through them because the workforce shortages. If we had an AI that could at least triage them or autonomously report some of the normals and take that out of the system, and leave the abnormals for a human to really look at in detail, maybe those patients who are anxious at home waiting, not knowing an answer, would have an answer faster. Maybe the ones who had the cancers in that pile could be put to the top and get that answer quicker and see patients. But then at the same time, we think about, okay, there's no human in the loop. What about those ones that get missed? But at the same time, what is the balance? Because it's hard to win all the time, but where do we get the biggest wins? And I don't know that we necessarily evaluate the pros and cons of both sides of it. We think, if we do AI, certain people are going to be missed out. But, there's also a danger of not including AI, and, maybe sometimes a human can't be in the loop all the time, but there's still possibly more benefit from that than doing nothing and leaving them waiting for hours on end. So that's what I would try to put into that.
This pile of scans that there was no one to have a look at, it's also a problem of lack of staff at this point. Should be AI be coming to solve that problem, or should we also be trying to solve the problem of the lack of staff before?
If we have staff to be able to train, that would be great. But do we have that? I don't know.
Yeah, I think the answer is obviously yes, but it's going to be a bit of a longer answer, right? So first of all, the more clinicians can be involved, not just at the deployment of the system, but from the early stages of development, ideation, giving feedback, providing high quality data, working with the engineers and the researchers on the technical side, and vice versa. I would say that there is a clear benefit, and some of the best work I've seen done in this field to date has been with engineering teams that have engaged with clinical experts very early, that really they're not experts and they have not become experts really in this process, but they've learned about the domain, about the use cases they were covering, and this allowed them to design better systems. Same goes for patients. And soliciting feedback from patient groups throughout all stages of development. I think there is a lot of mention in recent years of participatory engagement, participatory studies in the field of AI, but there is more of a mention of it than this actually being done. So I would like to see more people do that on a regular basis and for that to become a part of all the processes. I would say, however, that how to actually, and you touched on this, right, but how to actually envision the loop where the human would be in the loop is actually not a trivial thing. On the one hand, it's a question of scale and a question of how many humans you have and how many decisions need to be made and how long it takes for a decision to be reviewed. At the end of the day, you want for AI to improve accuracy, improve quality, and you want for it to improve speed and save time and give more time to people to spend with the patients and their care management, right? So if a person needs to spend as much time reviewing an AI decision as they would have spent making the original decision, even if it's a well-reviewed decision, no time is saved, for example. So ideally, we want for a scenario where all of these sorts of advantages would sort of accumulate. But then there are other problems. So there have been some studies, I guess the other panelists will have been aware of them as well, probably lots of people in the audience too, that have looked at some early examples of trialing human oversight of AI systems in radiology and some other fields. And they were interestingly mixed results in the sense that, you know, on the one hand, sometimes you have this cognitive bias where people would overly trust the system, so not really engage. This was already discussed, and therefore not look as deeply and be able to correct AI if an AI makes a mistake. On the other hand, there was also the opposite effect where clinicians would not have enough trust when it comes to AI and would override correct decisions based on their own biases and on those particular cases, let's say lower level skill, where you would not reap the benefits of the AI having been correct and the human having been incorrect, right? So then if you need to have multiple humans over viewing a single decision, then it becomes just even more time consuming. So yeah, I think some kind of a hybrid going forward where you could have very well designed AI systems that with a very, very high confidence can handle normal cases, easy cases, like any type of cases for which there is sufficient data to provide a guarantee. And then for people to really focus on the cases that are more complicated, require a bit more nuance, is likely the way to go. But we still need to resolve as a field this issue of clinical cognitive bias that comes into the review. I think this is a big open question, and a lot of people in the HCI, human-computer interaction field, will likely be looking into this issue and how they can correct it. I should just add, and finally, and then I'll stop, that well, this is obviously a very important use case healthcare, right, for AI and how to do the human in the loop. That it's not the first application of AI, and we can learn from other domains that may not seem as related at the first glance. Like you mentioned, obviously, chess and AlphaZero. I play chess every day, so I'm very happy about it. I know it's not as deeply societally impactful as solving healthcare. But chess engines and superhuman chess engines have existed for a long time, ever since Deep Blue and its match against Kasparov, which was ages ago, right? Let alone AlphaZero and the work that followed it that we've done. And you know, on the one hand, it's encouraging to see that chess is flourishing. So having superhuman AI can be a good thing for a sphere of interest. But also importantly, there have been tournaments early on in the development of AI in chess where now they had access to chess engines and they would play other people who have access to chess engines. So studies were done of what happens when you combine a superhuman intelligence with a human user. And interestingly, they found that obviously you need some level of chess skill and understanding to play well, whether you have a computer or not. But it wasn't the strongest individual players that achieved the best results given the chess engine. So what you need to have is, okay, both some level of technical literacy, let's say, but also a creative way of using the technological tool that you are given. So it was the people who knew how to ask the right kinds of questions and in the right kinds of ways of the AI that ended up having the best overall performance, rather than people maybe who were individually the strongest, but they would discard the technology maybe a bit too much just because obviously they're very strong, they trust themselves, which is a good thing, but they were underutilizing the opportunity that was given. And that's another very interesting problem. Again, I don't have an answer, but I think this raises some interesting questions.
Some comments there from the human on the loop thing.
Yeah, so I think, the rest of the panel mentioned the very important things that, having clinicians in the beginning to design, I think is really important. What I think is really an interesting issue is that we talk about AI, but AI is not one thing, and it's not like it's a spectrum, and actually, very importantly, the risk is a spectrum as well. So I think these are the things that we need to bear in mind. But the cognitive bias is a really important thing, and I think we haven't done enough research about it, and I think it's kind of really not prioritized as a research area to see how humans behave when they are interacting with AI. So I think that's a really important thing that we have to bear in mind. Another thing that, you know, we always talk about using AI to kind of remove the low-risk tasks. So I think as clinicians, and this has come in different conversations, that say, for example, a radiologist has 100 kind of scans to go through, and like 50 of them are easy. So then if you remove that 50 and then the rest of them that are very difficult, then would you then take into account how much cognitive load it is for them to then look at all the hard ones? Because, you know, I have a list in my clinic and some of them are easy. I say, okay, then I have like 20 people, 5 of them I can see. And then some of them take a bit longer. So I say for that, because of those longer ones, I have the shorter ones, so it compensates. But if you take away that shorter, you know, consultations and expect me then to see the other complex one in the same time, would that work? So there's so much nuances in the things, but I think I would say that there's always going to be a human in the loop, in my opinion, with AI. And I think I wouldn't envisage a time that AI is, I mean, it might be that we would have a completely independent AI that comes up with decisions, but I wouldn't see it in the near future. At least AI would be completely independent without a human supervising the decisions. Whether they would be able to supervise it appropriately, that's a different matter.
Would you like to start with any?
Yeah, so I'm thinking the risk of dehumanization. I'm just thinking of an example where a patient reports to the doctor and they've got a broken ankle. And the doctor says, okay, here's what you can do with your broken ankle. Just notice you've got bruising on your arm. Are you okay? Yeah, everything. I just walked in the cupboard. The patient comes back another few months later. They're feeling a bit tired. I've just noticed you've actually got a black eye. How did you get that? Oh, I just walked into a cupboard. You can see the point I'm making here. There's a bigger picture. The patient, I mean, that's something that's quite obvious, but the patient who goes into an appointment and is counting under their breath and then answers the question, counts under they have debilitating OCD. Or the patient that keeps looking to their side to talk, to kind of converse with the schizophrenia they're struggling with. These things can be missed because that's not what the patient is presenting with. This is a signed-on effect, like problem, that these things can be missed. There's a bigger picture. It's not just the situation the patient has or is struggling with or is presenting with. And I worry about that being missed because AI can't be all things and everything. It doesn't see these little details, and the ones I picked out were quite obvious. There are far more subtle ones that you might not see. The beginnings of somebody struggling with an eating disorder or struggling with a particular type of depression, or there are just so many, you know, and I just don't think it's there yet to cover all of those and do what it needs to do effectively.
Is that context knowledge that the
Yeah.
human can have?
Yeah, but also
that
is the
AI
patient,
system would miss?
the patient needs to feel able to say, actually, yeah, I'm struggling with that. Are they going to feel safe to say that to a robot? They don't know, doesn't really exist.
Do you agree with this?
But I think that's the situation. I think we're not saying, when we say about use of AI, that's not what we're meaning. So I don't think that you would see a future where you're going to just go to a robot GP and then that's not how it's supposed to be. It's supposed to help with the pathway of the doctor's work. So, and say, for example, we're talking about radiology. So you've broken your ankle. So then if the AI helps the doctor figure out what's the broken, so then the doctor has more time to actually pay attention to some other clues.
If there's a doctor there and they haven't been written off by AI.
It wouldn't. That's what
You
I
say
do not
that.
think. I do not think it would be, and I don't think it would be. And I think that going back to ethical AI, which I think we should all be aspiring to, and having medicine has always had the highest bar for ethics. And we have the 4 pillars of medical ethics that we are, as medics, are bound to, like do no harm, be beneficial, have justice, and give autonomy to patients. And I think no matter what technology comes, as physicians, we are bound to those values. And I don't think that there would be a time that the medical profession would let this kind of take over in that sense.
I hope you're right, but how many times have you phoned up a phone line to get help from a customer service department for Argos, a post office, and you go through a robot, and it's infuriating, and the robot says, can you give your postcode? And you give your postcode, and it reads back your postcode incorrectly. No, that's incorrect. You go round and round and round in circles. There's never a button you can press to go, no, I just want to speak to a human. Chatbots, they exist in every single company I seem to know of, and they're infuriating. In my experience, they don't get it right most of the time.
With IBM, we've been testing the IBM bot, and it was pretty good for anxiety and depression. Sorry, but not no more than that. But as service users, we fed it, and it was actually pretty much more efficient than a lot of our staff, have to say. And also, from my perspective, in living in Lambeth and representing service users there. We never see a psychiatrist. I don't think I've ever seen a psychiatrist other than my friend who I trained with here at King's. So we're seeing very, very young staff in mental health, and our services are so stretched. So in that way, I can see real benefit in using it. And our gigantic waiting list that I look at and I've been part of, if we can speed up the admin and triage, all those things apply. I think absolutely the points about mental health, like you're saying, principles, a lot of that is out the window as an inpatient. You have no autonomy, you have no control, you're under rapid trank, all kinds of things that I've seen and thankfully don't have to be part of because I'm not a clinician anymore. But I want to be going to psychotherapy, but I want to be using AI, and I think use the power of PPI, I'm going to vouch for that as public and patient involvement, because there you do have the interface, and that's highly nuanced, and it takes us sometimes years to work out what on earth we're going to do, and hopefully haven't run out of money, but usually have, and how much pressure we're under. We've got to be more efficient, otherwise more and more people are just not going to be with us.
Thanks, Emma. Was just thinking to close this block on the clinician's role, was just thinking about the value of tacit knowledge in the big picture, because it was Nenad that was saying, some clinicians could overtrust the system. It could happen that novel clinicians that still haven't gained enough experience to build the clinical criteria, they are overtrusting just because they feared for not being having the right decision, so they just leave it to the AA system. So there is still a value on tacit knowledge, the knowledge that is gained by experience, right? What is the role of tacit knowledge now? I think that Susan could make a point on that, because, you should be combining your tacit knowledge with the response from the AA system.
Absolutely, like the two combined together and using creatively is more powerful than any individual on its own. I think we all think about AI as welcoming it into our team as another member of our team, but the problem we have as, I think, clinicians is we don't know what level of member is that, I would treat a trainee very differently to a med student, very differently to a professor of my specialty. I don't know what level the AI fits into that and how much to test it or train it or value it or believe it. And I think we're still trying to figure that out, but as you say, our own intuition and knowledge holds so much value. We just have to learn how to work effectively with it.
The two developers in the room, what is the role of this extra member in the group of
I think the systems are getting better and better, which is great to see. Obviously, there is still a long road to go. I think even when we don't speak of the more clinical context and people coming with very specific problems, they need to get imaging done or tests, so it's already something very serious, maybe even a more preventative role or a role that future potentially personal AI assistants can play in helping people navigate some issues outside of the maybe clinical pathways. There is a lot of potential. Looking way back before AI, right? Or anything that would refer to as AI nowadays, I still remember there was this running joke about search engines. Google has one, I guess, where if you have some symptoms and you search for what you have, you're going to be diagnosed with cancer. I mean, these are the things that are going to pop up, right? Because this is what used to happen before. So, now we speak within the context of AI, and obviously there are risks there, and, potentially it can be wrong and so on. But I would say, if you look at all of these surfaces today and compare them to where they used to be 5-10 years ago, there is a lot more reliable medical information people can find and better advice, and it's far from perfect by any means. But I do think that things are going in the right direction. I wouldn't be able to, assess the level of these systems in a human way just because they're not human. So I would say this is maybe another point that's worth making, and this is why human-machine teams can potentially be so impactful, is that the types of mistakes that a machine can make are different from the types of mistakes that a human would be likely to make. One famous case, I guess, in the field of machine learning are adversarial examples, which is maybe not something that would actually take place in regular clinical practice. But the fact that you can, maybe for those in the room that are not as technically versed in computer vision, I guess mostly, maybe not exclusively, you have this thing where you can take an image of whatever, whether it's a dog or a cat, doesn't have to be a medical application, and you, in a very targeted way, perturb just a couple of pixels in the image, something that's imperceptible visually to a human observer, and the system will flip its prediction to something completely nonsensical, right? So this is a failure mode that humans wouldn't have. We still see the image as it is, but in the data manifold of the AI or whatever has been learned in the depths of the neural network, something can misfire and go wrong. But then obviously, if you have a human in the loop in a system like that, an error can never occur of that nature, right? Because that failure mode is, strictly speaking, a machine failure mode. It's not a human failure mode. And vice versa, there are some types of mistakes that humans may make that an AI system of some sort would be very unlikely to make. And finally, we've mentioned fairness and values, and fairness in machine learning research is becoming, well, has been for a while, a very important topic, but it's becoming an ever more important topic with an increased number of deployments and applications. But it's also worth noting that when you read through why it's such a big problem potentially, not just because of the actual impact which we want to have, like equitable care and so on, is that there are a lot of existing biases in human care. And then when we train machine learning systems on data coming from systems that have these biases and unequal outcomes, then the machine can learn to replicate them, and then that's a problem, right? Which is why we're doing work to try to rectify them. But taking a step back from the AI itself, this highlights a big problem that is unaddressed. So we can see machine learning models both as tools, but also as mirrors of the processes that we have in place. And also this speaks to the fact that there is a great opportunity of issues that these deployments may help to fix, because if there is this rampant injustice of various sorts, and if people, even after all this time, are not necessarily objective, they, it could be subconscious or it could be direct discrimination. It could take many shapes and forms, the systemic injustices in healthcare. But with AI, we can help flag some of those potentially and in some way address them. Now, how this is done in practice is obviously a very complex question. But I think there is a great opportunity for that in particular with the help of technology, not with technology maybe autonomously, but with the help of technology to really address some of those pain points going forward.
I'll start with a technical view on this. If you have seen 20, 30 years ago when the first MRI machine was built, actually was built in this country. I don't know, if you Google it, you will see the images you could get from the very early MRI machines were terrible. But for the first time, clinicians, they had a view now to human brain. You can't open up a living human brain's look at it. And then those are gradually started getting better and better. Obviously, the healthcare systems had to work out what is the safe way of implementing MRI machines. Now, a lot of neurological disorders heavily depend on MRI scans or a lot of other sorts of diagnostic measures. They are not perfect. Still, they look at the resolutions. What is the current one? 11, 12 Tesla? Yeah. And it's very expensive. Not many hospitals will have them, but they're getting better. And over the past 3 decades, they have improved. Now, when we talk about AI, there is, in some cases, in a regulated framework, they can give us some insight to human disease, to population health in a way we could never do before. Like, for example, part of my research is in dementia. Early screening for dementia is non-existent. Like, there are lots of people at higher risk of dementia, but there is no method at the moment. The only time you will see me as a dementia patient when my symptoms start popping up and I go and see my GP, I'm referred to a specialist, a memory clinic. Now, if you have an AI, I'm not saying within an ethical framework, within not discriminating against certain populations, certain demographics, certain ethnic groups, but if you have a reasonably good one, you're moving from complete like ground zero to like improving it by 10%, 20%, and then you build up on that. And then healthcare systems need to work out how you start implementing this thing safely. And often when we talk about AI, we assume a perfect, like heavily like expert clinician sitting in one place, which in a lot of healthcare systems that doesn't exist. We think of a full automation. It's never going to be like that. As Ellie says, always you need to design with a human in the loop, sort of a semi-supervised way of dealing with it. And also we are always thinking of very, very high risk. Of course, there is an AI application for very high risk applications, but there are a lot of things day-to-day clinicians face which AI can automate as long as it doesn't make it up. For example, you spend a lot of your time writing radiology reports. Obviously, there was in the news, if you've seen it, there was something which you dictated and recorded it and started making it up. Again, you have to measure to make sure it's safe. But that can open up a lot of clinicians' time in a much safer environment rather than going very, very niche area of detecting something can be very highly risky.
Another comment on, so you were saying, so about the data that you have. So as developers, you can try to make the best algorithms ever, but you will always have a limit, which is the bias on your data, the existing bias already. So are we never to be able to fight against this?
Yeah, I think there's a lot of drive now, at least I know in the UK. There's HDR UK, which is trying to develop like data banks that they have kind of safe environments where you can have anonymized data, where the scientists, they can have data from all the country. They're collaborating with a lot of healthcare providers to then have all the data in one place, and so scientists can apply to go and work on the data where the data stays where it is in a safe and secure environment. So I think there's a lot of drive, and actually I think this government is trying to progress that to make data available for research and for the benefit of the population. And I think this is a really positive direction. I'm quite excited about what the future holds. And I don't know, I think then it depends on who is going to then benefit from using that data, whether I think then there's going to be a debate whether it's going to be research, whether it's going to be industry, for the benefit of whom this is going to be used. And I think a multifaceted approach would be the best, because a lot of times these data is used for research, and then if you want a product out of it, a lot of times you need a lot of investment, where then the industry has that money. So then there needs to be a question that who then gets access to use that result of that research or access to that data to develop products that is useful for health.
Yeah, I would add to that. I mean, it's a big topic again, but rather than go all the way into it, one does need the entire ecosystem. I don't think it's a very simple question with a simple solution. It's obvious to say the more data, the better, the more representative, inclusive data, the better. But there are also various types of limits. As was mentioned, normally training these models requires data of a certain quality, collected in a certain way. Maybe, when it comes to imaging devices, they're not deployed in certain environments where then you don't capture and you don't get data in a certain format. There are various socioeconomic factors that go into shaping the data that you see downstream. So it has to be a very holistic solution. I would say, though, that there are various other deeper questions and privacy implications and so on. Like, for example, we're mentioning fairness, which normally, and again, it's a big topic, but to simplify, normally means something like for the groups of interest and the intersections amongst identities, again, that one needs to look for in the data to guarantee some level of equal performance where everyone can benefit from technology. Definitions vary, how one approaches these groups potentially varies, but that's the gist of it, right? But then you need to be able to A, measure the effects, and B, if there are discrepancies, mitigate and correct the discrepancies to reach some kind of a fair, robust, safe system. Now consider something like sexual orientation and gender identity. It's not the only such example, but it's an example. It's a set of marginalized communities in many countries in the world, maybe in some countries more so than others. And it can also manifest in healthcare and the types of issues people face and how those issues are approached. In mental health, which was, I guess, mentioned as one of the areas, there is quite a big discrepancy also in base rates of different conditions or pathways for management because of environmental stressors and so on and so forth, not to open again yet another big topic. But then the problem is, if you want to dissect model performance on an identity of that sort as a feature, you can't do that if that is not in the data. But this is very sensitive private data. And it also, for a very good reason, tends not to be included. Now, I'm not here to suggest that it should or it shouldn't, but it's more a fact that one is currently unable to fully measure the impact of technology on certain groups because of a lack of data. And I'm not sure if some of these initiatives or systems are looking into addressing that in some ethical way as well. But there are some practical obstacles as to how these things ought to be implemented in practice.
A very great point about how to incorporate protected features in models that you made, and Payam about the bias in data.
First to start with, if you have bias, that reflects our socioeconomic, socio-demographics in our data. We should, of course, in models we have to start working on technical solution, but reflecting on that first, it shows where the inequalities are. That's something we should actually highlight. If there is a bias, we should actually highlight. Say, when I designed this, I had, 80% men and 20% women in my data set to start with, and that shows maybe men got more scan than women for whatever reason is, or I just used the trivial example. That first. Second part of it, the bias itself is not necessarily a bad thing. There are certain diseases, for example, will affect certain demographics, certain ethnic groups higher. For those groups, actually, you want your model to be biased. You want to be able to detect that groups much better. And also then when it comes to, like Susie had an interesting example of the work you showed when people looked at pediatric and then started filtering for age groups, the model's accuracy changed. Like you can also, when you design an algorithm, for example, you can report how your model, how accurate you are. Let's say if I say my model again 90% accurate for overall age groups. Between age 70 and 80, I can say how accurate it is. And then for each, for example, age group, you can report how accurate you are. Now that brings up a very important aspect of this design. A lot of machine learning models, AI, in the end, let's say if you're making a prediction, will give you a number. That number is let's say if it's a probability, it's 0 and 100. If they're a little good, they will give you a confidence on that. That's another number. Now they will say how confident they are. 80% you have this disease and 60% I'm confident. Now if you show that to a doctor, a lot of them, what to do with this information? Is it good, bad, how the confidence? And that brings an issue of the endpoint of these things needs to be designed by end users, receivers of that, also social scientists and designers. Because what my model predicts as a risk, how I show it to clinician will have a huge effect on how they're going to interpret it. I can make it a traffic light. I can give it as a number. As Susie said, I can put patient's face on it as well. I can say in X number of times I detected like this was the outcome. And X number of times I detected like this, I was wrong. And then you can add many layers of how you present. Now, again, if you add too much information, that's going to, again, sort of set back the criteria. That comes like, again, you need work as a multidisciplinary team, then bring social scientists, designers to be able to design that. Raquel says I'm talking too much.
No, it's okay. Very interesting. I mean, I could be discussing here for longer. So we are going to be finalizing the panel now, but we wanted to make a final question to each of you. The same question for everyone. So, we have called this event a roadmap for an ethical AI in healthcare. We would like to hear from you just one sentence to highlight what would be for you the main challenge of that roadmap. Oh. Susan.
I think two main challenges, agreeing on what should be in the roadmap and
Also revising it as we progress. I feel that sometimes people feel it's a huge body of work, we've done it, end of, but we should be aware that things change with time and we constantly have to revise it.
Who wants to go now? Oh, no one. Okay, Jenny.
I think AI can be incredibly useful and incredibly helpful, but I worry about bias, I worry about mistakes, and I wonder how many people have to suffer before it gets made into something that's more perfect. And that's my concern, the people who have to go through the suffering.
Who's going now? Nenad, maybe?
I would say, I mean, in the spirit of what we'll be discussing, it's how to make this be holistic and to take everything into account. I think a lot of the times, sorry, you said one sentence, but I'll make a slightly longer sentence. A lot of the times people do approach technical development in terms of looking at the technical solution in isolation. And then, as you said, you get numbers out and you judge whether those numbers are correct. But really judging the system as it's integrated in a full pathway and all of the consequences that patients experience, the experiences of the clinicians using the system. So finding ways of more reliably evaluating that and taking it into account in early development as well.
Yeah, I think also exactly as others were saying, I think we should all, I'm very positive about the whole thing. And I think if we use this technology in a controlled way and constantly evaluating, learning from its mistake in small steps and being able to, we need to make very kind of apparent feedback loops. I think that's a really, really important bit that we quite often kind of fail to do. Have proper feedback loop to understand how it's not working well. And then it requires a lot of things, educating public, educating clinicians, bring everyone in this journey together. I think that's a hard bit. We need to all work together on this and then learn from it all kind of in a kind of coherent way. And I think it would be a really positive change.
If you're asking, I agree with all my co-panelists what they said. If I want to add one more thing to that, if I'm deploying something and I start seeing sometimes makes mistakes, how long should I wait to retrain it? How long should I wait to stop it? I don't have an answer for that, but that is an important part of it.
Before you deploy, you must have tested it many times.
You will make a mistake. I mean, no matter how many times you test, you deploy in a new environment or in real world, you will make mistakes.
Yeah, an example of that is the current system where people are identified with CCTV, and if they're black, they're more likely to be identified as someone who's doing something wrong, even if they're not doing something. That's just, and I don't think they don't think they created a system thinking that would happen.
Emma.
I agree with all of the above, the integration, and I think for mental health, where we're so strapped for cash, ridiculously so, have a look at our figures, Sattel and Maudsley. I think the interface that, as I've said, the interface we already have in public patient involvement is a really solid basis. There are some real pioneers in it, but they're so pocketed around the country, I guess. But I think speed up our admin and treat people and not hold people to account, but look at the mistakes that we've made. AI can gather them together, save more lives.
Thanks very much. That was great. We still have time for a couple of questions from the public, if you have one. Yeah.
It's really bright lights.
Sorry for being late and not having a medical background, so forgive me if my question is really stupid. I think I heard a lot of information which is really valuable. I think you talk about ethnic bias, etc. But I think one of the things I think about is some bias are intentional, right? Because maybe the people who is feeding the information has a bias, himself or herself. But some bias are unintentional or maybe being neglected. So it's more like, for me, it's more like neglected bias, because there are two things I think are impacting the AI. One is who fed the information, and the other is what is fed into AI. And a lot of things, a lot of patients or diseases and also treatments, I felt like is being researched very differently in Western countries, in developing countries, and in less developed countries. So I felt like the data we fed into the machine may be a majority for some diseases, majority covering the Western population. And for population in the underdeveloped countries or underreporting diseases, for example, mental health is very underreporting in developing countries such as China, where I came from. So many information I felt like they are less fed into the data to begin with. So it's not a humanly intentionally made bias, but more like unintentionally lack of data, a lack of what is put into the system. So I don't know the answer, but I can't help thinking, is there a way, maybe not now, is there a way we can track this somehow? Because that could also cause unethical treatment or diagnosis for people who, for example, coming from underreporting, underrepresented population. Maybe similar to the example that Dr. Nenad mentioned for the minority group in terms of gender or etc. But there is also minority in terms of who were reported, who were not reported. So it's more of a challenge I couldn't think of with my limited knowledge. I'd love to hear your opinion. Thank you.
Yeah, maybe I can jump in really quickly. I think, as you say, this is a very big problem. So it's not a problem that's going to be solved immediately, I would think. But I think we all need to do our part to make this better. And in particular, like one issue that comes to mind, especially as you were talking about this, is that the frameworks we have in place. So currently there are some frameworks in place in terms of protected characteristics, how certain types of analysis or performance need to be done to ensure that it's fair, etc. And these policies, they're obviously arrived at through some consultation, and eventually they kind of come through this social discussion process to the developers, who then do their best technically to make the solutions conform to them. Something like that, right? Obviously, the developers are a part of the conversation, but it's a much wider conversation that leads to these agreements. But I don't think that the current frameworks are sufficient. So I guess this is my main point. And what then people do is that they just follow the letter of what's in these policies sometimes. And this leads to very, very big blind spots that can manifest over longer periods of time. I guess one very easy example to make would be the treatment of immigrant populations, because sort of by definition, I mean, I know there are some frameworks in place for this, but there are certain rights that are granted to citizens and not granted to non-citizens. So non-citizens tend not to be covered by certain frameworks because they don't have the same legal standing, if that makes sense. And it's these legal standings that influence how definitions take shape that then people who do technical solutions, let's say, try to tackle. So xenophobia in general is a very big unaddressed topic. Xenophobia has been recognized as one of the social determinants and drivers of negative health outcomes, but it's almost not tackled at all in, let's say, machine learning fairness research. And this is a big problem. So even when it comes to topics like racism, which are age-centered, they're looked at through a slightly different lens normally, and this does open blind spots. Same goes for not really, I mean, in practice, not really tackling these issues as intersectionally as needed. People usually look at one dimension at a time rather at how dimensions of discriminations may intersect. And as you say, a lot of this is encoded in the data as a consequence of human decisions, and a machine that's merely trained to replicate patterns seen in the data is not going to have the knowledge to distinguish between what is a real effect and what is a consequence of discrimination. I think what was mentioned before also is that we need to get better as a community of defining what we mean by bias in a medical context, because you're completely right. There will be some conditions and some types of cases where we wouldn't expect for either base rates or outcomes or performance to be fully equal just because of some underlying genetic, heritage, biological sort of traits that influence certain conditions, right? Which is maybe not the case in other social applications of AI, where it's far easier. You really expect to see full kind of equality across all dimensions all the time. We've actually had a piece of work that was trying to look into how these models shortcut. So I think during your talk, perhaps there was a question on the study that was looking at chest x-rays and being able to reconstruct race from those chest x-rays. So that was indeed a very influential study that led to like a lot of discussion in the community. It turns out, I guess, according to our own investigations, that if a model does encode some such information on sensitive attributes, it may or may not be a problem contextually. Sometimes it is, sometimes it is not. We have some tools that may help kind of identify that. That's beside the point. But there is indeed a big risk of adverse outcomes if one doesn't look into it, if one doesn't explicitly check and try to confirm that the models aren't doing something that would have inadvertently bad effects to communities. And often, and this is why participation is very important in all levels. What is often the case is that the teams developing these types of technologies, they're fairly small teams. They're not technological teams of thousands of people. So within any such group, you will not have each identity represented. Just statistically, it's not possible. And that's why people from all circles of society need to be a part of the conversation. Otherwise, you may simply have a blind spot because it's not something your lived experience covers.
More worryingly, from a patient service user representative for the Maudsley as well, I think often I've been in a situation where I've been there just for appearances. Yeah. I've not been used. I'm there to tick a box. And it doesn't matter how much I say, how much input I try to put in, and you have to ensure that things are done properly. It's not just about ticking a box. And I don't know if I feel that that's safe enough to say, yeah, that's all fine now.
A final comment by Payam, and we will finish.
Again, AI is not going to be a magical one to solve all the problems, but sometimes, let's say, if certain attributes in certain population or certain diseases underreported, that itself, let's say, people, if they don't report their ethnicity and seems to be those which you have not available in your data seems to have worst outcomes, that reflects something about the sort of the social aspect of it, and it becomes a point of investigation. Very quickly, in population which certain diseases underreported, like in certain geographies, like let's say mental health, for various reasons, AI cannot solve everything, but you can look at other population. For example, the rate of certain mental health condition in a general population is 10%. Now, if in a certain population you suddenly go to the 0.9991, that can also highlight there is something. And again, as a computer scientist, as a data scientist, I work with data. Sometimes just reflecting on those things is very, very important. You can't solve it, but you highlight it.
Thanks very much. I think this has been the opportunity. Now, it's 2 minutes to 5, so we were really enjoying because we are overrunning a lot. But I have to say thank you very much to all of you, Payam, Susan, Nenad, Ellie, Jenny, and Emma. Thanks to all the public as well. It has been an amazing panel. So one applause for them. And for everyone, well, this is the end of our day today, about event on the ethics of AI in healthcare. Today, I think that we have sit together policymakers, academics, patients, AI developers, clinicians. We have talked about regulation. What principles should we using developers of AI? How crucial is trust and safety in our models? And what is, I think that we finished with an optimistic message. I think that we are in the right direction. Policy that is in place, and if not, it's coming. Initiatives are starting to be in place, and hopefully working for all and soon. We have seen together the need to be working together. It's very clear, discussing together, holding this conversation, and helping the AI to be growing safer and safer. Also, I think that it's important to preserve the role of patients' subjectivity, to avoid dehumanization, as we were discussing. And also, today we have seen, especially in this afternoon session, how important it is to identify groups of patients for which general AI might not work, as for example, children. Thanks very much. I would like to thank you also to all our funders. I don't know if we could put the presentation, Raquel, and so have a slide with all our logos, just so that everyone is happy. And thanks very much to Liz, also to Franca, to Alex, also to Nabila and to Lei for all your assistance today. And that's everything. Thank you very much. I hope that you enjoy it. Thank you.